Error. Electricity in line. Override accepted. Infusion initiated.
Welcome to the INS Infusion Room, the official podcast of the Infusion Nurses Society. In this podcast, we explore all things infusion therapy through a real-life conversation, covering the latest trends, new research, evolving standards, and key industry insights. Whether you're an experienced infusion nurse or new to the field, we aim to keep you informed and empowered with the knowledge to stay at the forefront of the profession. My name's Derek, and I'm your host. Let's dive in.
Hello and welcome to the INS Infusion Room. Today we have a very special episode that we're recording live from the exhibit hall at INS. And I have Dr. Victor Rosenthal joining us today, who just opened up our conference this morning, who had a lot of great information, and we want to welcome him onto our podcast this morning.
Thank you so much, Derek. It's a pleasure to be here.
Where did you travel from to get here? Miami.
Around 6 hours.
But you're all over the world often.
Yes, I used to go to 3 countries per month during 20 years, from 2002 till 2019, till the pandemic, going to Latin America, Asia, Middle East. I travel like 5 to 6 million miles.
Oh my goodness, I bet your airline miles are fantastic. That's great. So this morning, when I introduced you on stage, that was quite the impressive bio you have. You have a lot of history, a lot of contributions to the science, and you've led so many great research studies. So thank you for your contributions. But we mentioned what your H-index score was. And for those who are questioning what that is, would you mind to elaborate a little bit more as to what that is and what your updated score is?
Okay, yes. The H-index is the index that researchers have. And this is a combination of in which position are you as an author, first or senior. Senior is the last one. This is 1. 2 is the impact factor of the journal where you publish the paper. And 3 is the number of citations of all your papers.
Okay.
That's why this is changing. If you continue publishing in high impact factor journals, your H-index will go up. If you have more citations, the same.
And to give our listeners a little reference, what's a good score? What is prestigious?
About 25 to 30.
Yeah, so you're definitely above that.
Yeah, because no names, but many of my colleagues that are researchers have a score between 20 to 30. This is the
I
standard.
just wanted to highlight that because I found that to be very significant. On top of over how many research you led trials involving over 2,500 researchers? Or is that
Yes.
number bigger?
No, still around 2,500 people collecting data with us using our online platform that we provide for free to people worldwide, no matter the country of origin. And we publish by now 425 scientific publications, 154 are in PubMed, around 200 are conference proceedings, around between guideline standards and book chapters, around 40. This become this 425.
So all that to say, you've done a lot of work. That's just a little bit of what the bio entailed this morning. So anyways, I just wanted to highlight that for the listeners and talk about your recent work. So your session this morning was labeled CLABSI and PIVC infections in low resource settings. So talk a little bit about that. What are some key highlights that you want our listeners to know about from that session this morning if they weren't able to get that?
Complications of peripheral IV catheters was unknown. People used to think that PIV are harmless.
Mm-hmm.
And inspired by the fact that CDC and HSN will start asking to collect HOV. And because I have been collecting data of peripheral lines and central lines and BSIs, I had the opportunity to analyze the PIV-associated BSI. And I found that the CLABSI rate, central line associated BSI per 1,000 central line days, and my PIV associated BSI per 1,000 peripheral line days, one was twice the other.
Okay.
The rate of CLABSI was 5 per 1,000, and the rate of PIVC was 2.4 per 1,000. Meaning what? That if you prefer to avoid the use of central line to avoid having a CLABSI in your patient, and you insert 2 peripheral lines, the risk of CLABSI is exactly the same of using one central line, meaning that it is better to implement strategies to prevent BSIs whenever they are inserted the catheters,
Absolutely.
central or peripheral, instead of switching from central to peripheral to avoid the CLABSI.
So we talked a little bit about the impact, but dissemination wise, how can clinicians take that knowledge and apply it to practice?
Number
Tough
one,
one.
number one, if we include this data in standards, because people read standards,
Yes.
could help to improve the awareness about this. In another setting, when you are working at a hospital, when you are educator and principal investigator of the research, showing to the clinicians the rate of PIVBSI and CLABSI and the adverse events, extra length of stay, extra mortality, and extra cost, increase the awareness of them about this, especially when you benchmark this data with US and with the international report we publish every 2 years. This increases the awareness.
Yes.
And also training them to apply interventions and somebody watching them, like infection prevention is watching them and collecting data of compliance and then generating a report showing to them the gaps, help locally. I mean, there are two aspects. Globally, I mean, based on publications, and locally based on face-to-face training.
You mentioned that some really interesting statistics today about doctors versus nurses. A poll with the crowd of who they thought was better at hand hygiene.
Yeah, it's surprising.
I think we knew the answer, no offense, as a nurse to doctor here. But,
I am a man and I am a doctor.
Yes.
And to check the compliance of my peers, other men and other doctors, compared with nurses and women, I conducted a multiple logistic regression analysis in a huge database of 150,000 hygiene opportunities collected during 13 years. And with a multiple logistic regression analysis, I identified, like, with a significant p-value, which group was better? I forgot. Which group? I think nurses were better, no?
Nurses were better, yes.
Yeah,
I can confirm that. I can confirm that.
Meaning that we have evidence base to say the statement that nurses are better than doctors. On the other hand, we also compare sex, and we can say that women are better than men.
Yes.
As a conclusion,
so
men and doctors are the worst case scenario.
Yeah, and maybe they need more studies on that and how what triggers that, right?
Yes.
But you know, I think we saw that as a joke, and it was great. But it's a great start to something bigger, I say. So anytime that we have research, it spirals into something more and more studies and more studies. So can you talk about that escalation and what that looks like? How one study, or maybe you have an example of how one of your studies snowballed into something really big.
Yes, we are all aware here in the United States and probably worldwide about the bundle published by Peter Pronovost in 2006 in New England Journal of Medicine, that then was promoted by IHI, which has 5 interventions: hygiene, maximum barrier during insertion, skin antiseptic with chlorhexidine, avoid femoral, and remove the line when it's not required. This was excellent in Michigan, and he reduced the rate in more than 100 ICUs till almost 0. That's why people use worldwide. We use worldwide, but because there are some other things in low and middle income countries, we couldn't achieve the same results. We couldn't have 0. Our rate after applying this was reduced from around 15 CLABSIs to around 6 or 7 CLABSIs.
Great.
Then we conducted research locally in low and middle income countries to understand why is this happening, why we cannot achieve the rates of the United States. And we identify a couple of things that were outdated, like IV fluid containers.
Yeah.
Because in US we use collapsible, transparent IV fluid containers, fully collapsible, without the need of venting. But abroad, especially in low and middle income countries, they use semi-rigid containers with a needle or with a vent, or glass containers with a vent. And we conducted a study, compared these two IV fluids, and we found that the rate of CLABSI using the open IV containers, which are semi-rigid, glass, or burettes, is 3 times above the CLABSI rate of those using collapsible containers. This is one study. Another study was comparing 3 webs of COX against needle-free connectors. In randomized clinical trial with cost-effectiveness analysis, very strong result. We found that using 3 webs of COX, the rate of CLABSI was 3 times above the CLABSI rate of those using needle-free connectors. Meaning what? Meaning that the 5 interventions researched by Dr. Pronovost and applied in US were fine, perfect, but in low and middle income countries, we need to add more. And also, according to my audits, it's very common to do not cover with any transparent sterile dressing or gauze sterile dressing.
I saw that in your presentation.
Site. That's why there are a couple of things that should be incorporated to the bundle in low and middle income countries beyond those of US. I don't know if it's clear because I spoke a lot.
Let's talk about your new role with INS. Can we talk a little bit about that? Are we okay?
Of course. Yes, of course.
So I announced it a day, which it had been announced, but for the people who attended who maybe didn't know that, there's been a change within the standards of practice in the editor-in-chief role. We had Dawn, who is now retiring, and you are jumping into that role. Yep. So let's talk a little bit about what your thoughts are for that role.
I used to read the HICPAC, CDC, SHEA, APIC, IDSA recommendations, and they didn't explain everything regarding prevention of BSIs. And I started using INS to find these replies. And I found many things on the INS standards that I couldn't find in all these other guidelines. Like, for example, that when you use a needle-free connector with negative displacement, you need to clamp and then disconnect after flashing. And when you use the positive one, you need to disconnect and after clamp. These things are not available in all other guidelines. Or also, if you need to disinfect as straight lines or circular, this is only available at INS. And also the drying time of alcohol, chlorhexidine, or povidone is only available at INS standards. And I started following INS standards more closely than the other guidelines I mentioned before. And I had the opportunity to speak at Wokova last year in Prague in April. And
that's where you met Dr. Steinheiser.
Yes.
Right?
Dr. Steinheiser, Marlene, was there, and she liked my presentation. And she told me, Victor, we would like to invite you to present at our INS meeting in Las Vegas. And I accepted, of course. And I thought, oh, this is wonderful. I mean, I love INS. I love the standards. And I will be speaking there. And I will be close to these people, which are great people. They are replying something that nobody else is replying, and saving lives. Because when you publish something that prevents infections and other complications, you are saving lives. And then I learned that you could apply to be part of the committee. And I applied.
Yes.
And there was selection and interviews, and I was accepted as part of the committee. We are 16.
Yes.
And then when I was...
Which that's just now kicking off for the next set of standards.
Yes, exactly. So. Now we started working. This was a volunteer position as part of the committee. And then the position of editor-in-chief was open, and I applied because I love INS.
I love that. I love it. I'm so glad that you did.
And I applied again because I thought, okay, this is the place to be if you to conduct research and to participate in recommendations to prevent BSI infection, CLABSI and PIV. You need to be part. And I applied. And after a selection and interviews, I was appointed as editor-in-chief.
It's wonderful.
Surprising.
Wonderful.
I mean, this is a huge privilege and honor, completely unexpected 2 years ago, and unexpected until recently. And this is something amazing.
Well, I can tell you the INS team is very happy to have you on board. And I know that the members are excited to see the future contributions that you're going to have with the standards of practice. So thank you again.
Thank you. Thank
Yeah.
you so much.
Well, you have any final thoughts before we conclude today's episode?
Yes. According to this experience I have of around 30 years conducting research, data,
Yeah.
specifically published data, is leading interventions. If you have the opportunity to collect your data and to check the association with different products or behaviors, please publish it.
We
Please.
need publishing.
Yes, we need papers.
Yes, we need
There
lots of
are
papers.
so many gaps. Publish, because if you publish, we update the INS standards, and this go worldwide and help people to improve the compliance
Absolutely.
with what is required, and then we save lives.
Absolutely. And there are publications opportunities within INS itself.
Yes,
so
there is a journal.
the journal.
Yes. There is a
Fantastic.
journal of the INS. Yes, they are welcome to receive papers.
All right. Well, thank you so much for being a guest today. And as always, thanks for tuning in to the INS Infusion Room.
Infusion complete.